And the schedule system sorted the substances based on only 2 dimensions, only 2. And the 2 dimensions that they chose, and I put them in alphabetical order always. Are the abuse potential and
I'm not seeing anything on the screen. Oh, there you go. Never mind. I'm sorry.
got it?
Yes, ma'am.
Let's see if I can.
It just says schedule system right now. Is that all supposed to be up there?
No.
It just popped up on my. I think it's just going slow.
Mine says abuse potential, medicinal value, and then you put a line through system.
Okay, underneath it. The schedule system is the system. I'm
Okay.
getting a little dot. I keep creating dots here. I gotta quit creating dots here.
Yeah, I was going to say, and there's a bunch of dots all over the screen.
Perfect. Okay. I have to use it. Well, and if I try to erase it, everything will erase. So I'm not trying to do that. Okay. The schedule system used abuse potential, medicinal value to sort and organize them. So they created 5 different categories, and they used Roman numerals. So it was, let me put this up here just a little bit higher. Boy, this thing's annoying. Okay. 1, 2, 3, 4. Okay, they had, so Roman numeral 1 through 5. And they sorted them this way. Let me use this here. Okay. So schedule 1s have, come on, there we go. The greatest abuse potential and the least medicinal value. Okay. 2s have the next greatest abuse potential and a little bit more medicinal value. 3s have about equal abuse potential and medicinal value.
Wait a minute. So the 2s have greater abuse, least medicinal? Or is it just kind of making its way?
I need you to drop me off.
1 has the greatest abuse potential.
Okay. Okay.
Let me finish this thought and you'll see.
Okay.
I'm not drawing it perfectly, but I'm trying to draw it appropriately. Let me see.
Okay. Gotcha. So it just kind of continues to increase, decrease. Right.
So if you look across from 1 to 5, if you put them in alphabetical order, abuse potential, medicinal value, 1s have the greatest abuse potential, 5s have the least abuse potential. 1s have the least medicinal value, 5s have the greatest medicinal value. Okay, so the arrows get shorter across abuse potential from 1 to 5, and they get longer across abuse potential from 1 to 5, or medicinal value from 1 to 5. So here's how I might ask a question. Ready? True or false? Schedule 4 substance has a greater abuse potential than a Schedule 2 substance.
False.
Okay, everybody see that?
Yes.
Okay, so let me do one more. True or false? Schedule 3 substance has a greater medicinal value than a Schedule 4 substance.
False.
False, right, there you go. Okay, that's the kind of way I would ask questions. Okay, we go with this? So the schedule system created the Controlled Substance Act created the schedule system. The schedule system created the classification of psychoactive substances, but only based on these 2 dimensions. Okay, so you're going to see if you look at some of the substances in some of the classes, and you're not going to have to memorize any of those, but if you notice, remember they were classified in 1970, and that's where they started. And again, this is a federal law. So it literally, guys, takes an act of Congress to change a substance from one classification to another. So if you look at this, the Schedule 1 substances, include things like heroin, LSD, peyote, psilocybin, mescaline, MDMA, and marijuana. A lot of people go, well, marijuana, because most of those substances are banned. And remember back in 1970, remember the temperance movement went after LSD and marijuana, and they were banned substances. They have been for decades. Federally, marijuana is still a banned substance. The states are doing different things with it, but federal law still places it at a banned substance. Schedule 2, as you might notice, includes cocaine. Because remember, we talked a little bit when we did the history presentation that cocaine has medicinal value. It has the, it's a topical anesthetic and is still used in some cases, not as much today, but clear up until like the late 1980s was still used in some topical anesthetic formulas in emergency rooms as a topical anesthetic, okay, at a 0.05% cocaine solution. So it stayed at Schedule 2 for that reason. And if you notice, benzodiazepines like Xanax and Valium and Klonopin are Schedule 4s, right, which are very high in medicinal value and low in abuse potential, and yet we know that they're very highly addictive. And so when we talk in Chapter 4, we'll talk a little bit about what that means to have them sitting in Schedule 4 and needing to be changed, but it's not going to get changed until somebody literally takes it on the floor of Congress and they vote on it. So we'll talk about that a little bit later. Okay, we good with this? All right. Now we're going to go on to Chapter 2. And we're going to start with Chapter 2 on page 2.2. You guys have the definition as to what is a psychoactive substance, yes? We did that last week? Okay, I'm shaking it. Thank you. All right, so now we're going to talk about, in the second column over there, halfway down, you see the heading that says how drugs get to the brain. And at the very bottom of the page, it says routes of administration and drug absorption. We're going to call this section routes of administration, okay? Erase. Okay. Okay, routes of administration. And if you read the chapter, the chapter tells you that there's 5. I'm going to tell you that there's 4 because the chapter discusses these in terms of how fast they get to the brain. So in terms of the speed in which a substance is able to get to the brain, what then is the fastest route? What is the fastest way to put something in the substance to get it to the brain?
Injection.
Would it be injection?
Nope, it is not.
Is
Inhalation.
it inhalant?
Inhalation.
Inhalant then.
Which not everybody realizes is so, but inhalation. When you smoke a substance in, when you take it into the lungs, there are tens of thousands of little bronchial sacs in the lungs that are able to take in a very high concentration very quickly. And the entire right side of the heart, if you will, is designed to accommodate the lungs. So it goes to the lungs, to the brain, bang, milliseconds, okay, very quick. And if you remember, we talked about drug theme, historic theme number 4, and we talked about making substances, refining them, and making them more potent. Well, one of the ways in which you do that, one of the last steps that you do that with, is the high hot heat. So you take the substance, you put it in alcohol, and you melt it down, and it becomes a liquid. And then you take that liquid and you fire up the heat really high and really hot, and you evaporate off the alcohol. If it's a non-salt base substance. It'll be a tacky, sticky, amorphous kind of substance like your tar heroin. If it's a crystal base, though, like cocaine or methamphetamines, you'll get a crystal. Okay, so it'll be like crystal meth and crack cocaine. And these are the most potent forms of the substances, and these are the smokable forms. So we've made the most potent forms the fastest to get to the brain. Okay, then trying to color code this a little bit. So then the second fastest route becomes what?
Injection.
What kind of injection?
Intravenous.
Right, intravenous. Other forms of injection are not as fast. Intravenous is directly into the bloodstream. So it's going to be carried to the heart, to the brain in a matter of seconds. Okay. So we all know that, you know, the drug stuff or the needle stuff is nasty business, right? We know that we can share things like hepatitis and HIV and things like that, particularly the hepatitis, fairly rampant in sharing of needles and stuff. And I never met an addict who started out sticking a needle in their arm. It was something people progressed to. As a matter of fact, most clients I work with often said in the beginning, I will never stick a needle in my arm, only to find themselves doing it, you know, a couple years later. So why are people still using needles? Well, here's the deal. When you inject something directly into the bloodstream, the concentration of that substance stays fairly closely packed together so that as it travels to the brain, it hits the brain in a slightly greater concentrated form than it actually does than when it comes from the lungs, where it's a little more spread out, a little more diffuse across those bronchioles. So you get a greater, what they call peak effect. A lot of users call it a harder slam. When you inject it, that concentration will hit, and you know, they're looking for that rush. That's because after the first high, it is true, you always chase the first high, because nothing is ever as impactful to the brain as the very first time, because you start killing off brain cells, right? And you start depleting the ability to have that same kind of rush. So you look for ways then to try and create that. So you move from you know, ingesting it or smoking it to injecting it to kind of get a slightly greater peak effect. Okay. All right. The third fastest route then is the one I kind of take task with the book on, because I think they spread it out a little too much.
The mucus
And I'm going to
membrane.
call this section. I'm sorry, what?
Are we talking about the mucus membrane?
Well, I'm getting there.
Oh,
So we're going to call this particular part absorption. Okay. And in absorption, there's really two kinds of forms of absorption. First form is mucous membranes, like snorting it up the nose, acid in the eye, cocaine on the gums, places like that, where there are capillary beds very close to the surface. Okay, they get absorbed into the capillary beds, then to the bloodstream, to the heart, to the brain. It takes 2 to 5 minutes for this to occur. Now, there's several other forms of administration that can produce the effect in about the same amount of time, that are ways of getting it to those capillary beds. And let me type these up here. Be patient with me for a second, and I'll type these all in here. You can see them all. Let's do this. Okay, I have several. It starts out with other forms of injection, like intramuscular. So you stick the needle directly into the muscle tissue, right? In your arm, in your hip, in your butt, someplace where you stick it into the muscle tissue. Subcutaneous, sub-Q or cutaneous, and cutaneous is actually spelled with a C, C-U-T-A-N-E-O-U-S, but that's Latin for skin. So subcutaneous is, so you stick the needle just underneath the skin and you pop the skin up and you inject it. It's often done in places like between the fingers or under the fingernails, between the toes, or in places where you can't see because trying to hide the needle marks and stuff like that's fairly common. In people who don't want anybody else to know, or you can just stick it in, in the forearm and pop up the skin and stick it under there. That tends to create a lot of those skin sores and rashes and stuff, though, which is why they choose places with more flesh, like between the fingers. Sublingual, under the tongue, right? Transdermal, on top of the skin. It also includes suppository type, anal cavity. I've seen people who didn't want the alcohol smell on their breath because they were going to get in trouble if anybody smelled alcohol on them. This has been both in treatment lockdown places, the kind of work that some people do. They can't afford somebody to smell alcohol on their breath, so they will take rags, or you can take these thin mucus kind of almost latex sort of, only they're much thinner than that. They'll dissolve and stick alcohol in them and put them up the anal cavity, and it will dissolve and the alcohol will enter the system. I've seen people do that to take the shakes away a lot too. Again, not wanting anybody to smell it on their breath. So there's all kinds of wonderful imaginative ways that we can find to get it at least into the capillary beds and get it absorbed, okay? So then finally the slowest route of transport is going to be what?
Orally.
Right, we're going to call it ingestion. So we're talking ingestion, has to be absorbed into the stomach lining, then to the intestinal tract, then to the heart, to the brain. It's going to take 15 to 30 minutes for something that you ingest, a pill you might take or alcohol you might drink to actually reach the brain, which is why they often tell you if you're in pain, or if you've just had like some oral surgery, have the tooth pulled or something like that, they'll tell you take the pain medication right away to get ahead of the pain. So if you take, because it's going to take 15 to 30 minutes for it to kick in, and if you wait, you're going to be in a whole lot of pain a lot longer than you need to be. So I tell you, go ahead and take it, and by the time you really start feeling the pain, it'll kick in. A lot of my drinkers though say, well, Karen, it doesn't take 15 minutes for me I feel the effects right away. Yeah, no, you don't. No, you don't. Okay. What you feel in those first few seconds are, the opening of the can, right? I'm going to feel better now, right? All the things you tell yourself in anticipation of feeling better because you're going to drink, of having fun or feeling better, or whatever it is you're going to tell yourself. So never underestimate the power of your own brain and the power of mood chemicals. You can often lift your own, because you and I both know 15, 20 minutes later when you really start feeling the alcohol set in. And the time lag is an important factor. When we get to chapter 5, we talk a little bit about consumption and the increase in concentration. The fact that it takes this amount of time becomes a real factor in the conversation. Okay, we good with this? Questions? All right, let's go to, in the shell then, you have a couple of handouts that we're going to look at. So let's go in the shell. Lessons tab, we're in chapter 2, and we're going to take a look at the nervous system diagram. So, and this is I'm kind of going through the chapter summarizing things. So I'm sort of going, chapter 2.8 kind of starts the conversation about the nervous system. So I'm kind of going to summarize what's going on in there. And I have done so by creating this schematic diagram for you, kind of to break it down. All right. So hear me say, the nervous system is initially, hear me say that word, initially broken down into these two parts. The central nervous system, the CNS, which includes only the brain and the spinal cord, and the peripheral nervous system. which is everything else, okay? The central nervous system, the brain and the spinal cord, takes in, you know, all the information from all your 5 senses, goes into the spinal cord and up to the brain, where higher thinking functions process that information. So it's about reasoning, analyzing, problem solving, you know, those kinds of higher functions. Primarily, if you've taken your Psych 1111 already, you know, primarily frontal cortex kinds of things, and some temporal cortex, because you're or some parietal, I'm sorry, inside memory, language, those kinds of things sit in the parietal lobes, just behind the frontal lobe. And then peripheral nervous system speaks to the very edges of the occipital lobe in the back, which is vision, and the temporal lobes on either side, which have a lot to do with hearing and processing information, and sensory reflexes and stuff, okay? So the peripheral nervous system, because it's everything else besides the spinal cord and the brain, needs to be talked about in that it's broken down then further into 2 sections. The peripheral nervous system is broken down into the autonomic nervous system and the somatic nervous system. So the autonomic nervous system controls involuntary functions, all those automatic things you don't have to think about, right? Heart rate, respiration rate, blood pressure, body temperature, all that kind of stuff, right? The autonomic nervous system controls automatic functions, okay? And these functions are located at the very end of the spinal cord, the very beginning of the brain, called the brainstem or the hindbrain. Every member of the animal kingdom has some kind of hindbrain, okay, has these mechanisms in there that control the functioning of the organism, allows them to, you know, breathe or produce energy, or you know, respirate if they do that, circulate blood or things like that. So every living animal has some kind of an autonomic nervous system. The somatic nervous system covers other things like skeletal muscles, that reflex response kind of thing, right? You've seen somebody tap somebody on the knee with that little hammer and they kick, that reflex kicks. Okay, there's responses that go on in the sensory system. And then all of the like you touch something that's hot and you pull your hand away, stuff like that. Those are reflex responses. Now, the autonomic nervous system is pretty complex, right? It has a lot of things to do. The automatic functions are many, and most all of the organ systems are involved to some degree. And so we need to talk about the autonomic nervous system is broken down one more time into 3 parts: the sympathetic, the parasympathetic, and the enteric. So the sympathetic nervous system is the part of the autonomic nervous system that responds to excessive stimuli, like pain or danger. Okay, when the organism feels like they're in pain or in danger, they produce a response that has a specific name to it that we've all come to know as what's the response that we do if we're in danger?
Fight or flight.
Right, it's a fight or flight response. So a lot of people have heard that, and a lot of people have heard of one of the things that happens in the fight or flight response is that we produce large amounts of adrenaline. Okay, and a lot of people have heard of adrenaline, but not everybody, most people don't really understand what it does. Okay, when adrenaline enters the system from the pituitary gland, secreted massively into the system, it first of all, it speeds up all the organ systems, right? The respiration rate increases, the blood pressure increases, the heart rate increases, the body temperature increases. All of those things increase as a way to prepare the body to do some kind of action. And the blood, it causes the adrenaline, specifically causes the blood to flow massively into the muscles, which is why you've heard of stories of things like, you know, that guy who lifted up that car to save that baby, or, you know, things like that. It rolled over the tractor to save their dad, or, you know, the muscles can become, you know, 2, 3, up to 4 times stronger in some cases when there's massive amounts of adrenaline pumping. The problem is, you know, you only have one closed system for blood to pump. So if your blood is pumping massively into your muscles, it must be flowing out of somewhere. And it's actually flowing out of your brain. So, which is why you don't want adrenaline rush occurring for long periods of time, because over time it'll make you fuzzy headed, it can make you lightheaded, even and dizzy, it can even make you pass out eventually, and you're just not clearly thinking because the blood is leaving the brain, so you're not helping your central nervous system functions very much. And so let's think about, there are actually professions that people do for a living that keep them in elevated states of hyperarousal with this adrenaline rush for long periods of time, right? Soldiers who are in active duty areas, active combat areas, right? They're in this hypervigilant state while they're on patrol and doing things like that, sometimes for days at a time. Firefighters, police officers, first responders, and there are people who can, think about those guys who are fighting those wildfires out west, right? And women who are fighting those wildfires out west. The constant danger that they're in, so that hyper aroused state, which is why there's such exhaustion from somebody. I knew a guy one time who had done some hostage negotiation stuff, both in Chicago and in Detroit, and he talked about some of the standoffs that he had, 4, 5, 6, 8, 10 hours, sometimes longer. And so being just totally exhausted at the end of that because of that hyper aroused state. Okay, so the body is in that hyper aroused state. It can't really sustain that for very long, very well. So the body has a mechanism then to help the body pull out of that hyper aroused state and go back to average. And that's called the parasympathetic. The parasympathetic then will kick in once the feeling of pain or danger is gone, and I'm no longer aroused in that way. My body will immediately, the parasympathetic kicks in and brings me back down to what is average for me, whatever that is, and we call that homeostasis, or your homeostatic set point. Okay, so whatever your blood pressure typically is and your body temperature will return you to average. Now, if you notice, there's a third one here. Every organ system kicks into hyperarousal during fight or flight except one, and that would be the GI tract, right? The digestive system, because digestion takes a lot of energy, man, a lot of energy. And the body recognizes that it needs to save that energy, and it needs to shift that energy over to the actual fight or flight response to save itself. Organisms recognize that. So the digestive system shuts down when the sympathetic kicks in. Okay, and that's why, like, soldiers in active combat will tell you, they often go for days and days at a time without ever defecating. Okay, their system just doesn't process the food enough to create a lot of waste. It's also why the rations that are given to soldiers are very special. They're not regular kinds of foodstuffs. They're made very specially they make them very highly soluble, so that the nutrients can be absorbed much more easily without creating a great deal of waste in the system because of that. So, recognizing that those hyperaroused states occur and the body goes through that, and it's not good for the body to be in those states for long periods of time. So think too about somebody who experiences, frequent or chronic trauma or stress in an abusive situation, or whether it's as a child or in a living situation, or human trafficking. One of the big things about the victims of human trafficking are this amazingly hypervigilant state that they're in for sometimes months at a time, and the exhaustion and the toll that it has taken on all their organs and stuff like that because of being in such an afraid, hyper-aroused state for so long. So the body has this wonderful grand orchestration, guys. This thing works together to keep the organism alive and help it function. So let's take some examples. So car stalls on the train tracks and there's a train coming. Oh my God, danger. Okay, the autonomic nervous system will kick in, right? And you'll feel that, oh my God, and your heart will start pounding and you start sweating. The somatic nervous system will kick in. You'll start kicking at the door and pounding the steering wheel and trying to get out. And the central nervous system will kick in and say, unlock the door, get out of the car. Okay, and all of those things happen simultaneously until hopefully the organism is saved and we no longer feel it, and the parasympathetic pulls us back to homeostasis. Okay. Okay, we reach for a hot pan on the stove, okay, and burn our hand. So you have that immediate autonomic response, right, where like your heart goes up through your throat, right, that, and then your somatic will kick in and cause you to drop the pan and pull your hand back, that reflex response. And then the central nervous system kicks in and says, go over to the sink and turn on the cold water and put your hand under, okay. All of that happens at once until the parasympathetic puts us back to homeostasis. It's an amazing, amazing orchestration for the organism to stay alive and stay healthy and viable. It's important that it all works together well. You know, why are we talking about this? Because what psychoactive substances are able to do is to directly interfere with that orchestration. Okay, I have had clients, for example, who have stood there burning themselves with a cigarette with no response to pain. Right? Putting their arms through plate glass windows with no response to pain, only to tell you that the trip was a good one. You know, standing in the middle of the highway, watching the headlights come at them with no response to danger. You know, somebody, thank God, somebody realized and saves them. So one of the things that psychoactive substances can do is break down this wonderful orchestration that helps keep the body alive. Okay, questions? All right, so then we're going to go one more level down. Now we're going to talk about how that occurs on an individual cellular level. You know, the body orchestration will vary some from person to person, right? There's some variation between human beings. But when we go down and we talk about a nerve cell and what happens to the body on the cellular level, this is the level at which people cannot deny this kind of stuff happens to everybody. And then its cumulative effect takes on a little bit of variation. But the last thought we have is to talk about what happens on the cellular level. So you have yet another handout in your Chapter 2 folder. If you want to pull this up while I'm talking, and I'm going to use the board. Stop. Let me take you with me again. It is this. It says nerve cell diagram. Okay, I know it doesn't look like what the book looks like, and I'm not the greatest artist, but if this shows up on the test to be labeled, it's going to look just like this. Okay, so I put it in your shell like this and numbered all of the lines pointing to things so that you could practice labeling the parts of the nerve cell if you wanted to. You can print this out or pull this up on your screen and practice labeling them and kind of hide the bottom. Or tuck it under or whatever if you print it out and practice labeling them, because you're going to need to know the parts of the nerve cell, both because the diagram might show up to be labeled and or there may be some questions related to the structures. Okay, so the first thing I'm going to do, and I'm getting ready to lose my voice because I've already taught almost, 3.5 other classes today is what it's been, and I don't want to lose my voice in the middle of this. So let me help myself and pull up this conversation real quick. Ready? So in your shell, you have a diagram. One of the handouts, it says nerve cell diagram. I'm not an artist, so it's not the greatest picture you've ever seen, but it's functional. It works. I've been using it for a while. So here you have a picture, if you will, of a single nerve cell. And we're going to label the parts of the cell first, so we understand the language and the words that are used. Then we're going to talk about what happens when a nerve cell fires. Then we're going to talk about what happens when drugs are present in the bloodstream as nerve cells try to fire. Okay? Kind of as we did with the nervous system, we labeled it, and then we talked about how it works. Then we talked about how that orchestration can get disrupted when drugs are present. Okay, so let's label first. So, and there are some kind of different pictures or better pictures. If you did the homework assignment, hopefully you watched those couple of videos where we talk about neurons and how nerve cells fire a little bit. So let's just kind of go over that. You may want to watch that again after we have this discussion if you want to. But at one end of a nerve cell are kind of thread-like little tendrils, if you will, that are collectively known as dendrites, like mitochondria and stuff like that. So we call this part the cell body, If you've ever taken an AMP, you may know it as the soma. That's acceptable, but for our purposes, we have the cell body. So when these little chemical reactions occur, that energy travels to the head of the nerve cell where a much larger chemical reaction occurs, okay, and then travels, the energy from that travels down this long part here called the axon, okay, the axon, A-X-O-N, okay. And this part down here, the structure at the end here, collectively is known as the terminal foot. And inside the terminal foot are little sacs known as vesicles. And inside the vesicles are individual chemical molecules known as neurotransmitters. Okay, neurotransmitters are very specific chemicals that send messages to the cells to tell them what to do in order to tell the body in general what to do and how to react. So neurotransmitters are the mechanisms that make the body function, actually function. There's also one more structure we need to pay attention to, and that is the space between two nerve cells, because there's a lot of activity that takes place in that space. And that space has a name, and it's known as a synaptic cleft. Okay, so we've labeled the parts. We've talked about this big chemical reaction happens here. From that big chemical reaction, energy is generated in the form of almost like an electric impulse, known as the action potential. The action potential then travels down the axon and kind of hits the terminal foot, if you will, with some force, opening up what we call channels, ion channels, at the base of the terminal foot. And the vesicles are able to release then through those channels the neurotransmitters into the synaptic cleft. Okay, that's what happens when a nerve cell fires. The chemical reaction is created, the action potential is sent, it hits the terminal foot, the neurotransmitters from the vesicles then are released into the synaptic cleft. Okay? And the idea then is to, well, there are three things. Let's talk about this. Let's go to the, we okay with this? I'm going to go to my whiteboard. We're going to talk about that can happen to a neurotransmitter. NT is the abbreviation for neurotransmitter, when a nerve cell fires. Okay? One of three things is going to happen. One is that that neurotransmitter will bind or attach to the receptors on the head of the next nerve cell, on the dendrites of the next nerve cell. So they bond to specific neurotransmitter attaches to that specific receptor site, and when that lock and key fit happens, it generates a small chemical reaction again, and when enough of those are generated, right, it sends the energy to the nerve cell, the body of the nerve cell, where the big chemical reaction is generated, and another action potential. So nerve cells are lined up in what we call firing chains. So they fire from cell to cell to cell, carrying the information up to the brain and then back out again. Okay, so it's important for these cells to fire. If you kill off one of those nerve cells, which you can do in multitudes of ways, physical damage, chemical damage, injury, accident, drugs, any those lots of kinds of ways you can damage or kill off nerve cells. When you lose a nerve cell, you don't just lose the cell, you lose the entire firing chain. Now, these chains are packed very close together in the body, in the brain. So about 65% of those neurotransmitters will be absorbed by nearby pathways, but you're going to lose 35% of the neurotransmitter's ability to carry information every time you kill off a firing chain. Okay, so that cumulative effect over time will begin to significantly affect functioning. And nerve cells are not like skin cells or hair cells or nail cells. They do not regenerate on their own. The only way that you can stimulate a nerve cell to regenerate is under very specific laboratory conditions. Excuse me. Because if you've ever known anybody, or if you've ever had any nerve damage yourself, you understand that nerve cells just don't grow back like that. Okay, when I had my car accident many years ago, and the metal door slammed into me, the metal cut my legs very badly. I almost lost my one leg. And so I have really bad scars at the tops of my legs. Okay, well, that accident's been, 20 years ago. And to this day, you can stick me with a pin in those scars and I can't feel a thing. There's no feeling in those, that scar tissue in the tops of my legs because all the nerve cells have been damaged. So even this long later, okay, so I know for a fact, nerve tissue does, people think, well, you can, grow liver tissue and stuff like that. Well, under certain conditions, you can grow back parts of pieces of liver tissue. But if you could grow back an entire organ, okay, we wouldn't need to do heart transplants and liver transplants and stuff if we could grow them back. We can't, we don't have that technology yet. There's no way we can regenerate nerve cells in that way. Okay, so when they're gone, they're gone. I think people, especially when they're young and healthy, think all that stuff's just going to repair itself and grow back, and that's not what happens. And the second thing that can happen is that so when the nerve cell fires, there's actually sort of like a strobe light effect where it fires, and then there's this millisecond instantaneous pause, if you will, so that all three of these things that can happen to clear that synaptic cleft for the next firing. So one of the things that happens, especially to the chemicals that are still pretty close in proximity to the cell it fired from, to that terminal foot it came from, several of those neurotransmitters actually kind of get sucked back into their original vesicles in a process called reuptake. Oh, that's what reuptake is, okay? So they go back to their original vesicles as a way to kind of clear them, the tract, okay? The third thing that can happen is the other thing that takes place when a nerve cell fires in that instantaneous pause is that an enzyme comes into the gap, passes through the gap, and kind of, I call it, vacuums out any extra neurotransmitter particles that are still left in there. So what can happen then is they can get, I'm going to call it vacuumed out by the enzyme. Okay, so they either bond to the receptors on the next nerve cell, they go back to the original vesicles in reuptake, or the enzyme comes along and vacuums it out. So now the cleft is clear, we're ready for the next firing. And it happens. Of neurotransmitters when interfere with when a nerve cell fires. Okay, everybody good? Now let's talk about, we're going to do this in a different color. The four things that can, interfere with the movement of neurotransmitters when psychoactive substances, we're going to call PS, when psychoactive substances are present. Okay, so there's fourth, so when drugs enter the bloodstream now, if you remember, if you weren't with us for the last conversation, you need to go back and look at that, because the drawing that I did on the whiteboard in there about looking at receptor sites and neurotransmitters and then drugs and how they fit together was really important. You need to go back and get that visual in your head if you didn't see it. If you did, what I'm talking about here is, right, the I'm going to do that. Don't worry about it.
The reason psychoactive substances are able to cross that blood-brain barrier to begin with, remember, is because they're chemically similar to one or more of the neurotransmitters that already exist up there. So they're chemically similar enough that they're able to interact with or mimic the things that the neurotransmitters are supposed to do. Only they're not exactly the same as the neurotransmitters, so they end up not producing the same effect. What I mean by that, I mean by one of the first things that happens when to affect this movement of neurotransmitters is that the drugs can block receptor sites. So remember the drug chemicals are chemically similar enough to the neurotransmitters that they can kind of lock in the space of the receptor site, but it's not a perfect chemical fit, so it's not going to generate the chemical reaction. So when enough of the drug molecules bond to those receptor sites, it doesn't allow for enough of those little chemical reactions to take place, so the big chemical reaction never takes place, and the nerve cell never fires. So they can occupy that space, but decrease the cell's ability to actually fire again. So they can block the receptor sites. That's one of the things that drugs do. The second thing the drug can do, and if you'll notice it parallels these things over here, one of the things that also exists in the physical makeup, if you will, of a single nerve cell is something that you read about in the book, but I didn't put in the diagram because we really only have a couple of classes of drugs that this is pertinent for. Every single nerve cell in the body is actually lined with a layer of fatty tissue known as, I'll put it down here, known as the myelin sheath. Okay, the myelin sheath is a thin layer of fatty tissue that surrounds every nerve cell. So when we talk about there's certain classes of drugs that get bound up in the fat cells in the body, you know, my little overly skinny little drug users come and say, well, I don't have any fat on me, Karen. It's not staying in my body. No, baby, we're not talking about the fat cells. We're talking about the fatty tissue linings. Okay, different things. And so just because you're not fat doesn't mean it doesn't stay in your system and get bound up, because it does. Okay, so one of the things then, one of the ways that those substances work is that they actually block the vesicles. So the neurotransmitters cannot escape during that firing because they get bound up in that layer of fatty tissue that surrounds that terminal foot and doesn't let them out. Okay? So rather than allowing them to come out and go back to reuptake, it blocks those vesicles from even letting them out in the first place. Okay, the third thing that psychoactive drugs can do to interfere with this movement is to block the enzyme doing its job. There are some that are very specific to be able to block that enzyme. The most common enzyme that does this work is known as monoamine oxidase. You may have heard of MAO or MAO inhibitors. A lot of times in the commercials they'll say, do not take this substance if you're on an MAO inhibitor. Well, monoamine oxidase does lots of functions in the body. MAO inhibitors were actually the first generation of antidepressants many years ago, decades ago, because the idea was if I could block that enzyme from wiping out all of the chemicals in the synaptic cleft, if I left some of the chemicals in there each time the nerve cell fired, some of those levels would rebuild themselves, because depression is a lack of many of those neurotransmitters being produced in the brain. So if in a single firing I leave some in there and it fires a few more times and I leave more, it kind of rebuilds the levels of those neurotransmitters and works as you know, to reverse effects of those lowered chemicals. The problem is MAO also does a lot of other things in the body. It's very involved, for example, in cardiac functions. So in those original first generation antidepressants, if they put you on one of those, you had to make sure you didn't have any kind of heart condition or problems or anything, because it was necessary not to block the MAO in other parts of the body. Okay, so then we said that there's four things So we have the things that get blocked, and obviously when you block stuff, you're decreasing the effects. So this blocking often occurs with substances like depressants and tranquilizers and opiates and things like that. But there's a fourth thing that can happen that's very different and very specific to a different class of chemicals. Typically all of the stimulants are able to do this. Instead of blocking things and kind of shutting down that movement and that energy, the stimulants are actually able to cause the brain to what we call flood. So this flooding, and what that means is all of the neurotransmitters kind of fire and come out at the same time. There's no pause, there's no cleaning up. There's like this constant movement of energy, the neurotransmitters into the class. It's like pumping a surge of electricity back into a circuit breaker box, man. You're just gonna blow up the circuitry with too much energy too fast. And so what stimulants are able to do is blow up those nerve cells because there's too much energy too fast and there's no relief. So flooding is the effect of particularly the much stronger forms of stimulants. Okay, so we see how this is what's supposed to happen, right? This is what's supposed to happen. This is how it can change when you add drugs into the system. So when somebody says, well, I can take this drug and nothing's going to happen to me, wrong. You cannot make this stop. If you put the drug in your system, right, and that includes the alcohol, you put it into your system, you are creating these effects on the cellular level, whether you want to admit it or not. This is happening. Obviously, the more intensely you use and the more often you do this, the more of this type of damage gets done over time and becomes cumulative. Okay, so it's important to be able to talk. So as we talk about that entire 40% of the population that.
Okay. All right. That was very helpful. Saved my voice. So let's, there's a few more pieces that go with this. I'm going to talk about one of the PowerPoints. We're doing pretty good on time. If it's okay, you're always welcome to, run to the bathroom or something like that if you have to. But I'm going to keep going so that we'll be done in the next 30 to 40 minutes and we'll be finished for the evening. Fair enough? Instead of taking a break and trying to come back and all that good stuff. Okay. All right, here we go. All right. So then let's go back to the shell. And there are in chapter 2. Go below the homework assignment. There is a PowerPoint. Let's talk about this that I created to talk about. Let me enable the editing. Okay. So I'm often asked to come and speak at this group or that group or some. I speak a lot at, for example, at the Families of Addicts meetings and try and help the families understand and stuff. And so one of the things that people like for me to talk about is, the whole stigma about addiction and the idea that people think that it's a choice. Well, what does it mean to say that it's a disease? What, I hear people here call it a disease, and what does that really mean, and why is that discussion? So, the fun part is they very typically, when they ask me to do these little speeches or whatever, these little mini lectures, that they say, tell us everything about why addiction is a disease in 20 minutes. Okay, so I'm going to show you this first, and then we're going to expand on the thoughts a little bit. So I kind of created this as kind of the beginning of a conversation that has lots more depths and parts to it that we'll tap into as we go along if we can, okay? So let's start this way. You guys already know the definition of a psychoactive substance. We did that, but I always do it for my audiences, so I include this slide. Any substance that can cross the blood-brain barrier and interfere with the average chemical connections within your brain, okay? And again, this PowerPoint is in your Chapter 2 folder. It's the first thing right below the homework assignment. So, doesn't everybody use drugs sometimes? The truth is 30% of the population never picks up a psychoactive substance, ever. And there's reasons for that. religious reasons, cultural reasons. For some people, they've been surrounded by use most of their lives, and they're like, I'm not doing that. That's just not my thing, because they've seen the effects and so forth. So there are reasons why 30% of the population never uses a psychoactive substance. So it is not true that everybody uses. However, it does mean that 70% of people in the U.S. have picked up a psychoactive substance. And we know that the first substance that people tend to use are one of these three: alcohol, marijuana, and or prescription drugs. Those tend to be the first ones. Now, we've often heard people talk about, alcohol, marijuana in particular being gateway drugs and all this kind of stuff. And, just because I smoke weed doesn't mean I'm going to go on and use heroin. And okay, so not everybody who uses alcohol or marijuana or a prescription drug goes on to other substances, but I never met an addict on heroin or cocaine or crack who didn't start with one of these. Okay, so they are in that way gateways. Why do people pick up to begin with? Well, there's a variety of reasons. We talked a little bit about some of those reasons, right, in chapter 1 when we talked about the historic themes, and we talked about coping, and we talked about pain, both physical and emotional. But in more modern times, there's some other things that have kind of piled onto the party, if you will. And one of those, flat out, you guys, is just curiosity. I've had many a client say to me, well, Karen, I just wanted to see what it would do. I always love the person though who gives the drug to somebody else, especially unbeknownst to them, so they can watch what it does to their friend. I had a lady give her friend GHB, which is a date rape drug. She gave it to her friend. She put it in her friend's drink and didn't tell her so she could see what it would do. Okay, those are friends. Curiosity. And then of course the old fitting in and acceptance, and so those are in addition to things like the spirituality, and some of the other things we talked about in chapter 1. But there are reasons why people pick up. So what happens though is, out of that 70% though, 30% of that 70% has tolerance levels. And what that means is tolerance is how much of the substance it takes to get you the effect. And usually for most people, tolerance builds over time, and it takes more and more of the substance to get you the same effect. But, and as I'm going to show you later what tolerance is based on, we'll have that conversation. But trust me, for now, tolerance is the body's ability to process and break down a substance. Not everybody is capable of consuming high quantities of things. Some people just cannot break the higher concentrations down. They just don't have the ability to do that. Too much for them happens at low levels and creates things like nausea, sleepiness, discomfort. So this is a person who says, they have the first couple drinks and they know that if they have a third drink, they're going to feel sleepy or nauseous, or it's not going to be good, and they can't tolerate that much. Now, if we have a higher tolerance level, we tend to think everybody drinks like we do because we drink with people who drink like we do. And so we don't realize that there are people who walk around all night long with 1 or 2 drinks and the entire time. There are people who cannot process and consume any more than that. So they have what we call low tolerance levels. So then the remaining 40% can tolerate larger amounts in higher concentrations. So more parts of the brain can become affected for them. The effects are more intense to the organs and tissues and to the brain. Damage will occur, right? On the cellular level, those cells will die off and pathways will be lost and things will occur over time. But of that 40%, 25% of them will do these things. They will become what we call harmfully abusive, in that they will display a buildup of tolerance. They will show signs of withdrawal if they stop using suddenly. But after the withdrawal, the damage to the body and brain connections is there from exposure. So they do have lost brain cells. There is damage that has been done. However, their brain adapted to the presence of the drug, but didn't really change. So when the drug is gone, the receptors kind of went back to their average jobs, and chemical balances kind of rebalanced themselves. And it got used to, it's just kind of like having somebody, sublet the space for a while and then they leave. And so it didn't really change. It only adapted to the presence. So when the drug is gone, they do display physical and emotional damage from the use, right? When you're drunk and acting stupid, you're drunk and acting stupid, right? and you have high tolerance levels. You can get an OVI. You can, scream and yell and holler or hit your girlfriend or do things like that while you're under the influence. So they do have those kinds of things to clean up, messes to clean up, and things to do. But they're able to resume some level of functioning with no physical cravings if they put it down. The other 15 to 17%, however, responds differently. They display all the things seen with harmful abuse, right? The buildup intolerance, the withdrawal effects. But in addition to that, they had a genetic predisposition that was turned on, if you will, by the use. And your book talks about it a little bit. They talk about it in terms of epigenetic changes. We're going to talk about that a little bit more. The brain now has changed in the presence of the drugs. Changed. And I'm going to show you some of those changes. We're going to talk about them. Changes in, for example, the shape of the receptor sites. The receptor, when there's drugs up there, remember the drugs can occupy those receptor sites and it doesn't allow for the chemical reaction to happen. But over time, those receptor sites get so used to having the drug there that they actually begin to change shape so that they conform more to the drug than they do to the original neurotransmitter. So when the drug is no longer present, the receptor sites crave, if you will, cause the brain to crave the drug to be present. So the brain now desires the drug more than its original neurotransmitters, and cravings take over. And you guys, craving is like screaming going on in an addict's head, just screaming so loud that nothing else matters. Not work doesn't matter, family doesn't matter, kids don't matter, sex doesn't matter, nothing matters. Okay, nothing. I have to shut up that screaming, and so that manipulation to continue to use to shut up the screaming. And because addicts can appear to be semi-functional, like they can go to work and they can get some things done, we believe that those moments of functionality mean that they are rational and that they can rationally choose not to pick up again. But the truth is that screaming is still going on in their brain and is still driving this obsessiveness to go satisfy this screaming and quiet it down. And so even though they may be functioning, they are not operating from rational brain. We call it an addicted brain. That's what an addicted brain is doing. They can't fix this damage. Okay, we can put it in remission. We can stop using and we can quiet the voice, but we never fix the fact that that voice can rear up again. Okay, so recovery provides the tools to successfully manage this addicted brain. So what was the choice? If this is such a big choice, what was the big choice that the addicts are making? To use the very first time? Remember, 70% of the population made this choice. So 70% of people picked up, but only 15% of people developed this physical addiction and these cravings. Did they choose to have the genetic predisposition for physical addiction? They didn't choose that any more than they chose the predisposition for cancer or Parkinson's disease. Okay? They chose to keep using their brain. Now that their brain has changed, it is no longer in a rational state. So it's not a rational choice to continue using. So who gets to judge? Are some people just better than others? Or they have better character? They have more willpower? Are you sure? Because what if you were the one that had that predisposition? It's easy to think that it would be that simple to just say no, right? Until it's you. And I got to tell you, looking at the struggle, when I watch somebody in recovery, in early recovery, struggling to find that recovery space, and you can see the battle, the internal battle in their eyes. It isn't easy. They struggle and it's hard. And that's why sometimes they relapse. It's a fight. But the fight can be won. There are 23 million people in the United States today who are in active long-term recovery. So it can work, but it takes a lot of effort. Recovery is the choice. Addiction's not the choice. Recovery is the choice. So hopefully that begins to speak a little bit to how we apply this understanding of the physiology to the process of what we call the addicted brain. Okay. Let me do one more thing here. So let's talk about tolerance so that we have that full picture kind of done. I did this. So tolerance is one of the other things that has a genetic kind of link to it. So there are some parts of this idea of use and abuse and addiction that have genetic markers to them. So tolerance is about the body's ability to break down substances and eventually discard them. Substances break down with the help of chemicals from the liver called enzymes. After an enzyme does its job, it breaks a substance down, it goes back to the liver and says, if I've seen this substance once, I may see it again, and it will begin to multiply. So the more enzymes, the more of the substance they can break down. So as these, I call them army of enzymes, are multiplying, the more enzymes there are, the more of the substance it can break down. So tolerance builds, and I can break it down. I can drink more, and I can metabolize it and get rid of it. However, how large this group of enzymes gets is genetically predetermined. Some people are only able to produce a small amount of enzymes for that substance, so they cannot break down much fast enough before it becomes toxic and makes them sick, right? These are those 30% with the low tolerance levels who just cannot metabolize, their body can't tolerate because they don't have the ability to metabolize very big concentrations. Others, however, that, the other 40% that begin to be harmfully abusive or physically addicted have large armies of enzymes, okay, that are really efficient at breaking this stuff down. So they're able to produce much greater numbers of the enzymes, enabling them to break down much higher quantities of the substance. However, at some point, that army of enzymes will stop multiplying. Only a few years into use, they believe around 7 to 10 years, the enzyme will stop multiplying as directed by the genes. From that point on, the body uses that same army of enzymes over and over and over again to break down the substance each time it puts it into the body. Well, what happens to any piece of machinery you use over and over and over again, right? It begins to wear out and becomes inefficient. Now the body no longer handles those greater doses like it once could, and the drug begins to become toxic to the body. Even if you were able to tolerate high amounts, high quantities at some point, eventually those enzymes are going to wear out, and tolerance is a curve. Okay, that's the phrase you hang. Tolerance is a curve. It builds, and then as the enzymes wear out, the organs and tissues become damaged because we can't get it out of the system, and it begins to do damage to organs and tissues over time. You've heard of people, they call them functional alcoholics, because the curve for alcohol can be pretty long. Okay, it can be. However, it's a curve. And so people say, Dad's always happy when he's drunk. What's the big deal? Well, I always tell him, well, for now, Uncle Ralph goes to work every day. He goes to work for now, there will come a point where they will not be that functional if the using behavior continues.